Let me just introduce Joe Heyman. Joe is a former chair of the American Medical Association Board of Trustees, former president of the Massachusetts Medical Society, and just finished a 3-year stint as chair of the National Physician Association Board of Optum Incorporated. He served on the Board of Commissioners of the Joint Commission and the Board of Directors of Joint Commission Resources International. He serves on 3 subcommittees for the Office of National Coordinator for Health Information Technology, the Bryan University Advisory Board, and the Advisory Board for Digital Collaboration Solutions. He is the founder, former president of the Chief Medical Information Officer of the Whittier IPA Incorporated, a nonprofit organization of physicians in Merrimack Valley that owns and operates the Wellport Health Information Exchange. He practiced obstetrics and gynecology in both a group and solo practice for 41 years, having retired from clinical practice in March 2014. And with that, Joe, I welcome you, and please, I'll advance the slides for you.
So this is what we're doing. This is my mother-in-law. I have signed consent so that I can use her for display purposes. This is a longitudinal record that actually goes further over to the left, and it shows every encounter with the healthcare system, different practices. You can see the practice names at the top, and those little dots that you see there are progress notes. The bars are different problems, when they start, when they stop. If you went down further, which you can't on this because this is only a screenshot, and this is live actually, this is in our production environment, you would be able to see laboratory work. You would be from either Quest or from one of the hospitals that might be joining us. You'd be able to see X-ray results, vital signs, and if there were anything abnormal, you'd see a little red bar at the bottom to show that there was something abnormal below the screen. This is a typical progress note. This is not using EHX, but this one happens to come from a eClinicalWorks practice. This is done by extracting the HL7 information from the database at eClinicalWorks and then reformatting it into a progress note. We also do that from GE Centricity, and we also can, will be able to, we're in the process right now of doing this, be able to take something a little less detailed like a CDA from the eClinicalWorks SAS process, practices. We can also generate a direct message and take anything that's on the exchange and attach that clinical information to an encrypted direct message and send it to another provider, either within the HIE or on the mass highway to another provider someplace else in the state. And you can take as much of that clinical information as you want, and you can actually remove, you can take clinical information from more than one practice and attach it to the same direct message. There's also a single patient portal, and this is how the patient sees it and signs in. And as you can see, they can schedule appointments, request medication refills, request referrals, create and manage personal health records, address insurance and billing issues, and communicate with their providers. All of this, of course, depends on whether their provider is willing to accept these kinds of messages. And here you can see, this is what the patient would see. We don't have any patients signed on yet, just physicians, and I'll explain that in a minute. But as you can see, they get a consolidated CDA, and they get a summary for every single clinical encounter that they wish to download a CDA for. They can do it by practice. So the motivation for doing this was the need to provide services and products for our members without attaching imprisoning requirements for them to have to be with a single network or a single hospital. We wanted to have clinical integration for contracting purposes and to avoid antitrust issues, And we had the wonderful opportunity of being able to be part of the MeHI Health Collaborative. We were one of the communities that got a grant, and for that reason, all the physicians in our community had EMRs, hardware and software. Once again, the importance of physician independence so that they're not imprisoned, they can move from one type of practice mode to another. And this was way before ACOs, so we were just interested in improving the quality and efficiency of the care that we were providing. So after the MeHI Health Collaborative, we actually were attached to a vendor, and things didn't quite work out. And unfortunately, the most important thing for us, which was establishing a health information exchange, didn't happen. Part of the reason for that, though, was that we had outrageous demands about what we expected from a health information exchange 5 years ago, and the truth of the matter is that we're just developing that sort of technology now. We've learned that you've got to keep it simple. During that 4 years that we've been up until a year ago, we have had experiences with 3 or 4 major vendors, and in each case we got very close but no cigar. For example, we had one vendor that couldn't produce a single reference who was using ECW. We had one very major vendor where we were about to actually sign, and then they told us we had to have a hospital as part of the network at the very beginning, which was one thing that the IPA was absolutely opposed to, because we have 4 or 5 major hospitals, well, they're community hospitals in our neighborhood, and we didn't want to have one hospital be part of this and then not be able to get any other hospital to sign on. And then we had one vendor that actually quadrupled the price on the very last day. And we finally signed with Alere this past summer, and that's working out very well. And let me just say that one of the reasons that our relationship with Alere is working out well is because they were able to scale this to a small IPA like ours. And so as we get bigger, the amount that we pay Alere gets larger. But at least it's affordable, and we have a sustainable business model for the next 5 years. So first of all, we have this chicken and egg problem in Massachusetts because we have an opt-in environment. And to get physicians to sign on when there are no patients signed on is a problem. And to get patients to sign on when there are no physicians signed on is a problem. So we've been marketing to physicians, and right now, as you'll see later, we have 41 physicians signed on. It's about 7 practices. And they are live, and they are sending data, but the only data they can look at is their own patients' data because none of the patients have opted in yet. We had to get access to the databases. We had to do the reformatting of the HL7 stuff. We have 17 different vendors, and we developed a mission and vision, and we created 3 committees to help us administer this program. And we had to produce lots and lots of important documents. This is our vision and mission, and it's, you know, pretty simple. It's all involving trust, and it's also trying to make it possible for anybody in any system. We have patients up here in the Merrimack Valley. Very few of them are in just MeHI or just Partners or just BI Deaconess. They're all in more than one system, and they don't even know what system they're in. So we want to cut across all of that, and we want to allow our physicians to see a really complete record, not just a record from one hospital or one system. These are our operating principles. As you can see, they say pretty much what I just said. And I'm sort of rushing through because there's so little time, but as you can see, we won't share any confidential business data unless somebody requests us to do so. We will not sell clinical data, and we're really sharing these purposes only for treatment, quality measurement, and improvement in public health. The advantages of an IPA ownership is that patients are used to having physicians be the stewards of their data. The ethical use of data for improvement of quality and efficiency rather than for some other third-party purpose. Instantaneous access to aggregated data, no physician imprisonment, potential income stream for the IPA. We are able to give direct addresses, and of course, as already mentioned, it helps with the meaningful use achievement. The advantages of a regional HIE are that clinicians can see all of the patients in the community, not just the ones in their own system or their own hospital. No silos, improves the health of the entire community, improves efficiency for the entire community, the ease of a referral, and the fact that a patient doesn't have to have 12 different patient portals. They can go to one place to see all their clinical information. The long-term advantage is that we can do quality measurement for the entire community, quality measurement for any subset of the community, and the potential addition of new innovative services. So right now we've got 43 physicians on production platform. We have 101,000 patients in the system now. We have 794,000 progress notes in the system, and we don't have a single patient opted in. So we've got the platform live and running, and we've got a few more practices we want to get on board before we start opting in patients. So we're planning on opting in our patients sometime about someplace between 3 and 6 weeks from now. And if you go to our website, which is www.wellporthealth.net, you can actually see the marketing documents and stuff like that that we're going to be using to opt in patients. And that's my information right there that you can take for if you ever have any questions or want to talk to us. And by the way, we're interested in moving beyond just the Merrimack Valley. If anybody else wants to join our HIE, especially another IPA that doesn't want to have to go through what we've had to go through, more than welcome to talk to us.